hypertensive dyslipidemic with chronic tension type headache. He had history of ethanol and tobacco abuse. On examination, his vitals were stable and with signs of heart failure. JUV was raised and S3 gallop with fine basal crepitations. The ECG showed evolved anterior MI changes with curved ST segment STT changes in the anterior leads with T inversion. Chest X-ray showed cardiomegaly with prominent aortic knuckle and signs of pulmonary venous hypertension. The echo showed dilated aortic root with mild AR and significant MR with severe hypokinesia of the anteroseptum and mild pericardial effusion towards LV side and mild collapse of the RVOT. The aortic valve short axis level showed highly echogenic pulsatile mass near the aortic annulus and also the RVOT. The color Doppler showed mild AR and mosaic color flow pattern inside the mass, and we can also see the mass is near the main pulmonary artery without any compression or communication. The apical four-chamber view showed dilated LA and severe LV dysfunction with mild systolic collapse of right atrium and pericardial effusion towards LV also. And the final echo impression was large echogenic pulsatile mass near the origin of the left main coronary artery with severe LV dysfunction and EF of 30% with mild AR and significant MR with mild systolic collapse of RA suggestive of tamponade. Then we proceeded with CT coronary angiogram. The first image shows the takeoff of the left and the right coronary artery, and the right arrow indicates the saccular aneurysm involving the proximal LAD, and the left arrow indicates the dilated right coronary artery with ectatic changes. This is a 3D reconstructed image of the same. We can see the right arrow showing the saccular aneurysm of the LAD, and the left arrow shows the dilated and ectatic right coronary artery. Then he proceeded with coronary angiogram, which showed a proximal LAD giant aneurysm with distal TIMI2 flow, and the right coronary artery was ectatic with slow flow. So we moved on to additional investigations like MRI brain with MR and MRV to rule out any intracranial aneurysms. So there was no such intracranial abnormality was detected, and autoimmune antibodies were negative, and the whole body FDG PET was done, and it showed a proximal LAD non-FDG avid hyperdense lesion suggestive of hematoma with mild pericardial effusion. So the final diagnosis, CAD anterior wall MI with severe LV dysfunction with proximal giant LAD aneurysm of atherosclerotic etiology with ectatic coronaries with slow flow with post-MI pericarditis.
This is a talk about LV aneurysm, which is a rare manifestation of Castleman's disease. A 40-year-old gentleman presented with complaints of fatigue from 3 months, no comorbidities. General and systemic examination are normal. ECG was within normal limits. Other investigations, CBC and LFTs are normal. Only positive thing was inflammatory markers, ESR and CRP are elevated. Echo was showing abnormalities for which CAG and LV angio was done at a peripheral center at Shimoga, and he was referred to SJCR Bangalore branch for the further evaluation. This is a transthoracic echocardiography apical four-chamber view showing LV apical aneurysm with to and fro flow with no LV apical aneurysmal clot, and LV ejection fraction is around 45. This is a modified apical four-chamber view showing LV apical aneurysm with to and fro flow. This is a short axis view showing basal pseudoaneurysm measuring around 2 into 4 centimeters. The patient was taken to transesophageal echo, the apical four-chamber view, showing a basal pseudoaneurysm. There is a bicommissural view at 62 degrees, showing a basal pseudoaneurysm at 7 o'clock position. There is a LVOT long axis view at 116 degrees, showing LV apical aneurysm with to and fro flow with no LV apical clot. This is the same thing we try to demonstrate the apical LV aneurysm, true aneurysm, and basal pseudoaneurysm, two different aneurysms. LV apical being true aneurysm and LV basal pseudoaneurysm. LV basal pseudoaneurysm measuring around 1.2 at the neck of the pseudoaneurysm. This is a 3D reconstruction view showing LV apical aneurysm and the LV basal pseudoaneurysm. This is an LV angiogram showing LV apical aneurysm. The coronary angiogram of left and right coronary systems are normal, significantly normal. The patient was taken to cardiac MRI. There's a cine image on the left showing the apical aneurysm, true aneurysm. There's a axial section showing basal pseudoaneurysm at 4 to 5 o'clock position. At this juncture, we were considering the differential diagnosis of tuberculosis, aorta arteritis, sarcoidosis. Traumatic still in this case is not a cause, but we are considering it traumatic as 1DD, and infectious disease, Chagas disease being the rarest possibility, and ischemic can't be ruled out, even the coronaries are normal. The patient was referred to surgery for further surgical repair of aneurysm. The patient pre-op was evaluated with this differential diagnosis. PET-CT was done. PET-CT was showing uptake at the portocaval lymph nodes. This is a static image and the running sagittal sections. This is an axial section showing portocaval uptake, and LV aneurysmal neck of the cavities was also showing PET uptake. This is also a case report of Castleman's causing pulmonary aneurysms. Among the discussion part, the clinical spectrum is wide, varying from rapid onset of symptoms with life-threatening organ dysfunction. Asymptomatic unicentric Castleman's is common, whereas asymptomatic multicentric Castleman's is not. The main drug of choice, first line is cetuximab. If cetuximab is not working, we go for tocilizumab. The median response for chemotherapy, 33 days has to be there, and radiological regression, it takes about 3 to 4 cycles after the chemotherapy. Our patient, we have given the rituximab, even though rituximab is a drug of choice for HHV8 positive MCDs. The chance of relapse after the maintenance therapy, HHV8 can be positive, so patient was given rituximab on forward, and patient is on maintenance therapy, doing good on a telephonic follow-up. Thank you, sir.
Enigma. So I'll be presenting a case, a 35-year-old male patient, presented with vague abdominal discomfort since 2 weeks, breathlessness since 1 week, palpitations since 1 week, and on deeper probing, he also gave history of loss of appetite and abdominal fullness despite having small quantities of food. The past history was unremarkable. There were no comorbidities or no family history of any heart disease. On general physical examination, the patient was tachycardic and hypoxic. The BP was around 108 by 68 millimeters of mercury. JVP was mildly elevated. The cardiac examination was unremarkable, and the per-abdominal examination also did not show any significant abnormality. On evaluation, the ECG showed us sinus tachycardia with RBBP type of presentation. So we went ahead and did a transthoracic echocardiogram, which showed us a huge mass in the right atrium extending into the right ventricle. The LV function was preserved, and this was the 4-chamber view. And on subcostal view examination, we could see the mass infiltrating from the IVC into the right atrium. So this practically ruled out any primary cause or intrinsic cause of the mass from the cardiac chambers. So we wanted to find out the primary cause of this mass. So this is just a slide to show the measurement. The mass was around 5.8 centimeter into 3.2 centimeters in the right atrium, and it was completely filling the IVC. So with this presentation, we also wanted to rule out pulmonary thromboembolism. So we went ahead and did the CT pulmonary angiogram, which showed us bilateral pulmonary embolism in the main pulmonary arteries extending into the lobar arteries. We wanted to find the primary, so further evaluation, we got first of all, the patient was started on IV anticoagulation. We got a CECT abdomen done, which, as you can see, the right atrial mass, including the IVC mass, there is also some liver mets, and there is a huge mass in the right kidney. So based on the radiological evidence, a diagnosis of a right renal cell carcinoma with liver metastasis and a mass in the IVC extending into the right atrium was made. So at this point of time, the differential diagnosis of the mass was either a thrombus or a embolization from the malignancy. So we involved the vascular surgeon and a uro-oncologist also at this point of time, and the patient was planned for a surgery. The patient underwent nephrectomy and surgical thrombectomy. Intraoperative analysis showed the IVC mass extending into the right atrium was a thrombus and not a malignant tissue. So post-surgery, the histopathological studies revealed a clear cell renal cell carcinoma of the right kidney. The patient was discharged with oral anticoagulation. Patient is currently hemodynamically stable and is on chemotherapy for the liver metastasis. The patient continues to be on oral anticoagulation since there is an active cancer and he's on chemotherapy.
I will be presenting coronary curiosity, echocardiographic insights in anomalies. So here we had a 12-year-old boy who came to us with complaints of dyspnea class 2, mild grade left-sided chest pain, and easy fatigability since 2 to 3 years. On examination, he did not have any cyanosis or clubbing, and he had a pansystolic murmur, grade 3/6 in his left lower sternal border. His X-ray and ECG were unremarkable. There was no cardiomegaly or any abnormal waves. So on his echo, we saw on his apical 4 chamber that he had an RA-RV dilatation with a severe TR. On his short axis, we saw that there were collaterals through the interventricular septum. On further looking at a short axis at the aortic level, what was peculiar was that there was a dilated LMCA from the aortic sinus. We could not appreciate the RCA origin from the aortic sinus very well. So on further zooming in, we saw that there's a dilated LMCA from the aortic sinus, and the RCA origin was actually from the pulmonary artery. A color Doppler interrogation showed us a retrograde flow into the PA from the RCA. So here we can notice a retrograde flow into the PA from the RCA, whereas the dilated LMCA was from the aortic sinus itself. This is a further zoomed in image of the same. We went ahead and did a cardiac CT for this patient. We could see that the LMCA, the LAD and the LCX originated from the aortic sinus, whereas the origin of the RCA from the aorta was not clearly visualized. We could see that the RCA originated from the PA, which was again confirmed by the 3D reconstruction image. A cardiac MRI of this patient showed us Z scores of the RV more than 2, EDV and ESV. This dilatation was probably responsible for our severe TR.
Thank Dr. B. Ramesh sir for providing an opportunity to present a case here. An interesting case of dyspnea. Here is a 31-year-old lady pursuing a fellowship in rheumatology at Columbia University, New York, who presented to us with shortness of breath and palpitations from last 6 months. There is no history of angina, loss of consciousness, syncope or pedal edema, no previous history of hospitalization and no comorbidities, no significant family history of coronary artery disease or sudden cardiac death in the family. On evaluation in the United States in the Department of Cardiology, she was diagnosed with inappropriate sinus tachycardia. Then in our hospital, when she came, the clinical findings were absolutely normal. We further investigated her with an ECG and chest X-ray. ECG was sinus rhythm with normal axis. Chest X-ray was also normal, and transthoracic echo was also found to be normal. Then we subjected her for a functional assessment. We did a 6-minute walk test. We found that there was a hypoxemia with a drop in saturation to 85% after a 6-minute walk test. It was also noted that the oxygen saturation varied with position. In supine position, the saturation was 98%, and in sitting, it was 88%. And on exertion, that is after the 6-minute walk test, the saturation dropped to 85%. So after this, we conducted her, we came to a differential diagnosis of intracardiac shunt or intrapulmonary shunt, pneumonia, chronic thromboembolic pulmonary hypertension or cardiac arrhythmias. So she was further evaluated for the same. The contrast echocardiography was done with agitated saline, which revealed rapid right to left atrial shunting concerning of an intracardiac shunt. So the contrast agitated saline was positive within 2 cardiac cycles. And then the transesophageal echo was done subsequently to delineate the anatomy. It showed a thin and floppy septum with a PFO measuring 0.3 to 1 centimeter with a positive bubble study.
An uncommon cause of LV calcification. So Our patient was a 38 years old lady who was admitted outside in an outside hospital at Kolar with the complaints of generalized weakness and bilateral pedal edema since 15 days, and with the complaints of cough with expectoration and fever since 10 days, and breathing difficulties for 3 to 4 days. So over there, she was diagnosed as a case of dilated cardiomyopathy with an ejection fraction of 40%, with right lower zone pneumonia, with sepsis with septic shock. So over there, she was managed conservatively and was referred to our institution for further evaluation and management. So upon presentation at our hospital, the patient was still having complaints of dyspnea class 3 with reduced cough and resolution of fever. And on examination, she was afebrile. Pulse was 110 per minute regular. BP was 110 by 80 with having bipedal edema, and LVS3 was present, and bilateral minimal crepes, basal crepes were present. So the past history was that the patient is a known case of biopsy-proven FSGS NOS variant in May 2023 with a subnephrotic proteinuria of 1.3 grams per 24 hours, and for which she has taken some steroids for 6 months, but at present she is not on any immunosuppressants. And recent heart failure hospitalization was twice there within the last 6 months, and there was no significant family history. And investigations which was done outside in the last admission was, she was found to have anti-dsDNA positive, anti-histones positive, C-ANCA and P-ANCA was negative, and C-ANCA was equivocal, and anti-GBM antibodies was equivocal. Sputum KOH mount and gram stain was negative, and ultrasound abdomen done outside suggestive of congestive hepatomegaly with moderate ascites. So investigations which are done our side. So this is ECG showing a left axis deviation with left ventricle hypertrophy with pressure overload pattern.
Hospitals. Today, I would like to present a case of a neonate with severe pulmonary hypertension, but with a treatable cause. So, the patient was a 2-week-old baby boy born out of non-consanguineous marriage, and he was brought with 2-day history of fast breathing, poor feeding, and vomiting. So, on further probing, there was no history suggestive of sepsis or respiratory symptoms, and had a relatively normal urine output, and the mother has not noticed any yellowish discoloration of eyes or skin. And there was no history suggestive of seizures, and the antenatal history was unremarkable. So, there were no usual suspects at play. And at the second visit, the baby was tachypneic and cyanotic with cold peripheries, and the baby was intubated there in view of cardiorespiratory failure and admitted for further evaluation. And a basic workup was done where the CBC, electrolytes, renal and the liver function was normal. The blood and urine cultures done there later showed no growth, and the USG abdomen showed a hepatomegaly and no urogenital abnormalities. And after which a 2D echo was done, and the diagnosis of PPHN was made, and the baby was started on IV sildenafil, but there was no improvement, and the baby was referred to a higher neonatology center for inhaled nitric oxide therapy. So at the second hospital, a repeat echo was done, and the baby was continued to be treated on lines of PPHN. Baby was started on inhaled nitric oxide for the same, and supportive therapies in the form of inotropic support, IV fluids and antibiotics were started, but no improvement was noted on oxygenation. And the treating neonatologist, with a high index of suspicion for a congenital heart disease being the cause for such high pulmonary pressures, referred the baby to MHB. So at presentation, the baby was sick looking, was on ventilator support with a heart rate of 156 per minute, and was not maintaining saturations with a SpO2 of only 65% despite being on 100% FiO2. And the blood pressure was 58/46 millimeter of mercury with inotropic support, and the pulses were felt equally in all 4 limbs. And a cardiovascular examination showed a normal S1, the S2 was loud, and a soft systolic murmur was appreciated in the parasternal area. Bilateral breath sounds were equal, and the abdomen was soft, and hepatomegaly was noted. And the ABG showed that the baby had such severe metabolic acidosis with a pH of 6.9 and a lactate of 15 millimole per liter. And this is the chest X-ray showing cardiomegaly and diffuse groundless opacities in the lung fields. So after which a review 2D echo was asked, and here This is the subcostal coronal situs view, where we can see the spine in the middle, the aorta to the left, IVC to the right, but we also see a large vascular structure just anterior to the descending aorta. And as we tilt anteriorly from the same position, we can see the atrial septal defect between the right and the left atrium. And we also see that the jet is blue in color, showing that it is shunting right to left. And we see the free wall of LAS ball and the pulmonary veins forming a common chamber just posterior to the left atrium.